Here we go. Good afternoon. It's Friday the 13th, and we welcome you to the final installment of the Total Care for Parkinson's Ask Your Doctor webinar series, brought to you by the O'Donnell Brain Institute here at UT Southwestern Medical Center. Before we begin, we have a couple of reminders for you. Your participation is highly encouraged. We recommend using the chat feature so your remarks can be shared with the speaker at the appropriate time. If you do prefer to speak, click the raise hand icon so the moderator can see a question is in waiting. You will be asked to unmute yourself when it is time for you to speak. Please note, this event is being recorded. By participation in today's session, you consent to be included in the recording that will be posted for future reference. Should you not consent to be a part of this recording, please use the chat feature only. Without further delay, we welcome Dr. Sood to begin today's presentation.
Hello, everyone. My name is Anubha, and I lead the Total Care Program for Parkinson's disease here at the O'Donnell Brain Institute at UT Southwestern. I'm really excited to see all of you, a lot of new names, but also some familiar names who've been part of the program for a long time. So welcome all. Before we start, I just have a few announcements. This is the final of our series of Ask Your Doctor. We'll be doing many more of these, so look out for them. But our next series begins on March 20th. It's called Mind Matters, and it's going to be just really wonderful. I hope you all will register. We'll send out information about that. And then our annual symposium happens on April 25th. I hope you can all attend as well. And with that, I am excited to introduce to you all. I'm sure you know him as well. A lot of you are his patients, Dr. Vibhash Sharma, who is clinical lead of the movement disorder section and also medical director of the Neuromodulation movement disorders clinic here at UT Southwestern. So Dr. Sharma is going to speak to us today about surgical options for Parkinson's disease. Thank you, Dr. Sharma, for joining, and I'll hand it over to you.
Thank you, Anuba, and thank you everyone for joining this webinar. And I heard a lot of good things about this webinar and Ask a Doctor series. And I really appreciate Anuba and Janice for organizing this. I think this has been very helpful to patients and caregivers, and particularly, providing the information in a structured way. So today I will be discussing about surgical options for Parkinson's disease. I'll share my slides, and once I'm done with the slides, then we'll keep some time for the questions, which I think Anubha will be moderating that. So let me start by sharing my slides, and okay. Is that good? Okay. All right. So, surgical options for Parkinson's disease, why this discussion matters to you. So whenever I see patients in the clinic, these are the questions which come up most often. So many patients and families ask, when is it time to consider surgery? Will it really help? Is surgery a last resort? Am I a candidate? Or what are the risks? Now, surgery can feel intimidating, and I know there's a lot of information out there. So today, my goal is to present a clear and balanced uh, information so that you can understand when the surgical options are appropriate and when they are not. So let's review the typical progression of Parkinson's disease. Whenever we see patients in the clinic, we often go through a typical, timeline, which Parkinson's patients will go through. So Usually, like Parkinson's is diagnosed mostly when patients are developing some sort of movement-related symptom, whether it can be tremor or slowness, or it can be changes in their walking. But before the diagnosis is made, they are already going through what we call as like preclinical symptoms, which can include they could have some mood changes or sleep issues. But during this time, they do not have any movement related symptoms. But during that time, Parkinson's is building up. So once they are diagnosed here, depending on their symptoms, how much they're bothering them, medications are initiated, and medications works very well, and patients are getting better, their quality of life is better, and symptoms are manageable with the medications. So we typically use the term honeymoon phase during this early stage of the disease. And as the disease progress, patients can start noticing that the symptoms are getting worse after a couple of hours of their medication intake. And that's the term we use for off periods when the symptoms are coming back and they feel the need to take the medicine again so that they can see improvement in their symptoms and their quality of life gets better when the symptoms are controlled. So, but over the time, what happens is they go through a roller coaster of these off and on symptoms throughout the day, which can be disabling. Other thing which can happen is they can also develop medication-induced side effects, particularly dancing, wiggly movements, also called as dyskinesia. And that's kind of like their mid to advanced stages. And then as the disease progress with further loss of brain cells, they can go into what we call as late stage, where the medications are not really helpful for several of their symptoms. And then patients can also develop falls and then some other non-movement related symptoms. So during this stage, like mid to advanced stage, is when we are looking for more options, where we are like, okay, medications are working, but patients are still struggling. So, what can be done to really optimize their symptoms and improve their quality of life? So, that's when we are talking about the surgical options. So, it's important to remember that Parkinson's disease is always treated with medications first. So we usually don't think about surgical options early in the disease course or at the time of the diagnosis, but it's good for the patients to be aware about these options. But always, medications are initiated if depending on their symptoms. However, with progression, the management of symptoms can become difficult, like with the medications alone, and that's when patients are experiencing, off periods, or they can have unpredictable response to medications. They'll take the medicine, they are not noticing benefit, and then sometimes they'll notice benefit. So it can be very difficult for them to function in day-to-day life because they are struggling with unpredictability. Or patients can develop tremor which are not responding to medications, or they can have side effects from the medications, such as drowsiness or nausea, which are bothersome to them, or they can develop extra movements or dyskinesias from the medication. So they may be moving well, or tremor could be better controlled, but then they are developing these extra movements. Now, at this point, we don't have any therapy which can slow down the disease course. And obviously, there's no cure at this point. Efforts are ongoing. But because of that, we are looking for other options which can improve their quality of life and control their symptoms better. That's when we start talking about the surgery. Now, we always give an overview early in the disease course, but so that patients are aware. But when the right time comes, we are talking about the surgical options and which can be considered. Now, important thing to remember is surgery is not a last resort. We are not thinking about surgery when everything has failed, when we are like, okay, nothing is working, let's, think about surgical options. Think of surgical option as one of the several treatment options. You know how we think of several medications. Similarly to that, surgical option is one of the treatment option which is used thoughtfully at the right time. So we can consider surgical options when the fluctuations are persisting despite medication adjustment. So the first approach is if the patients are going through these ups and downs throughout the day or unpredictable response to medications, we are trying to adjust their medications first, or trying to add more medicine, or cutting down some other things, trying to improve their lifestyle. Maybe if they're having severe constipation, trying to improve that to see whether that can improve their fluctuations. Um, if that, despite these efforts, they are still struggling, then surgical options can be considered. Or when the dyskinesia the dyskinesia becomes bothersome. Now, a lot of patients can experience these extra movements after being on treatment for Parkinson's disease with levodopa after 4 or 5 years. Around 50% of patients can develop dyskinesia. But the important thing is whether these are troublesome to them. A lot of time they may not realize they are having these extra movements. It could be the family noticing these extra movements. But if they are not bothersome, we can still manage them with medications. But if they start to become troublesome and bothersome to the patients, or sometimes they can interfere with their walking, or they are so severe, or eating, or even in public places, patients start feeling socially awkward, so that's the time we are trying to optimize medication. And if again it's not helping, then we can consider surgical treatment. Other thing is tremor, which if it's disabling and not responding to medication, surgical options can effectively control the tremor. Medication side effects. So medications are effective for majority of the patients, but patients can also develop intolerable side effects. So if they are noticing excessive sleepiness, or they are having nausea or lightheadedness, or they are not able to take the frequent dosing, so that's when also like we can consider surgical options. And despite various efforts, if with medications, the quality of life is still declining, then we are looking for more options, and that's when surgical options are considered. So importantly, the decision is based on the symptoms and quality of life. It's not just years since the diagnosis. So it's not like an automatic algorithm where after certain years, we will consider surgical options. And I'll discuss that further in next slides. So the first thing for you all to know is what surgical options are available currently. So there are two primarily like surgical options. One is deep brain stimulation procedure, and the other one is lesioning procedures, which include focused ultrasound therapy, radiofrequency ablation, and stereotactic radiosurgery. Now, amongst these lesioning procedures, focused ultrasound has become very popular, and several of you have already heard and may have read about it. Radiofrequency ablation was an old way to do the lesioning procedures. It is not frequently done nowadays. Stereotactic radiosurgery, or another like commercial name is gamma knife, is also done occasionally nowadays. But again, the it has declined over the time since the focused ultrasound was approved. And then levodopa infusion therapy, like also was and still one of the option, in which particularly when a feeding tube is implanted, and then the carbidopa levodopa medicine is delivered to the intestine directly. So in the next slides, I will be talking about deep brain stimulation lesioning procedures in like more detail. So what is deep brain stimulation? So deep brain stimulation is a surgical technique in which a electrode or a lead is implanted in a specific region of the brain, and that is connected through a wire to a battery which is implanted in the chest, also called as pulse generator. Now, everything is inside the body. So nothing is hanging outside and nothing is visible. And what this pulse generator is doing, it's sending constant electrical stimulation to that specific region of the brain. For Parkinson's disease, the two commonly targeted regions are globus pallidus and subthalamic nucleus. And these are the targets which have been studied and were approved by FDA. And once the surgery is done, then patients are seen for programming where we are able to modify certain parameters to see how much electrical stimulation is delivered, at what rate, and for how much duration. So we are able to change these parameters to see what combination will work best for the patients. Now, the second thing is, how does the DBS work? What is the mechanism? So overall, the understanding is the electrical stimulation is trying to change the abnormal brain pathways or network. Think of brain as a very advanced electrical circuit. And what deep brain stimulation is doing is delivering electrical stimulation to that electrical circuit and trying to correct it. Now, it's never perfect, but it's trying to bring it closer to the normal. Other thing is also it's doing through the stimulation is trying to reduce the abnormal brain rhythms. So the brain communicates through these brain rhythms. And if the brain rhythms get impaired and disrupted, the communication is affected. And that's when patients develop these different symptoms of tremor, slowness. And what deep brain stimulation is trying to do is trying to correct it. Now, several studies were done, across decades, and they have shown that deep brain stimulation is effective in controlling movement-related symptoms. Now, on this slide, I have summarized like 4 pertinent clinical studies, and all of them have shown that after deep brain stimulation, patients notice good improvement in their overall on time throughout the day, and also improvement in their quality of life and reduction in dyskinesias. And we are also able to reduce their medications, but that can vary from patient to patient. But overall, there is some reduction of their medications. So that helps to reduce the side effects from the medication. Just to give you an example, if we focus on this figure where I'm pointing, what they're doing is they're comparing patients who underwent deep brain stimulation therapy with those who continued with the best medical treatment. And so patients were implanted with deep brain stimulation and they were followed over the time. And the patients who were not implanted with deep brain stimulation, they were kept on the best medical treatment or their dopaminergic therapy like levodopa, and they were followed over the time. And what they found at 12 months, the patients who underwent deep brain stimulation, they had around like 30 to 50% improvement in their movement symptoms, even when they are not on their medication. So just with deep brain stimulation, that's the improvement they could get. And the patients who did not get deep brain stimulation and continued on the medical treatment, they were about the same or slightly worse. But overall, there was not much improvement as compared to deep brain stimulation. So what that means like with deep brain stimulation alone, patients can experience improvement in their movement-related symptoms, and that can help to reduce the intensity of their off time. So even, it's never 100%, but when they're in their off state, they won't experience that severe, like intense symptoms, which they were experiencing before. So overall, it is estimated that at a given time, around 10 to 20% with Parkinson's disease can be candidate for deep brain stimulation therapy. But it's very important to remember that DBS does not benefit all patients with Parkinson's disease. So now in the next slides, we'll understand that who can benefit from this therapy. So who is a good candidate for deep brain stimulation? So you may be a good candidate if you have Parkinson's disease, where a good levodopa response, and if you're going through motor fluctuations or dyskinesias, which is impacting your quality of life, then tremor, which is not adequately controlled with medications. And also, like FDA has approved this therapy for at least 4 years of disease duration. Now, can it be done earlier than that? In selected cases, we have considered it, depending on how much the symptoms are bothersome and when we think that the diagnosis is accurate. Also important to note that patients should not have significant memory or thinking problems, or the surgery should be safe for them. They should not have several medical issues which can increase their risk of having the surgery. And the expectation should also be realistic, you know. So uh, they should understand that it's not a cure. It's still, the disease will still progress. It will not get rid of the fluctuations completely. So those are the things which we will discuss when we are thinking about their expectations. Who is not a good candidate? Now, there are other neurological disorders which can have Parkinson's-like features, but their progression is different, and they do not respond well to levodopa. So these are grouped in a category of atypical Parkinsonism. So these patients are not good candidate because they will not get benefit from these surgeries, and in fact, they can decline after surgery. And then another thing is like symptoms that do not respond with levodopa. If patients have developed a lot of balance problems, speech problems, and they are looking for an improvement in these areas as their primary expectation, then they will not benefit from DBS therapy, and they may not be good candidate. If the patients have developed significant cognitive problems or dementia, so they may not benefit much. On the other hand, there could be decline in some of these areas of cognitive problems. And then if they have several medical conditions that can make them unsafe for surgery, um, uncontrolled depression, anxiety, or psychosis is another area which we have to address before the surgery. So if until these are controlled, they may not be a good candidate. And again, unrealistic expectation about what DBS can do, whether will it get rid of my medication, if that's one of their expectations. So that's, again, DBS cannot do that. In some cases, yes, but most of the time, patient need to continue medications, whether it will provide 100% control of their symptoms or some other symptoms, So we discuss about the expectations in great detail when we are evaluating patients for deep brain stimulation. So now let's look at what symptoms improve with deep brain stimulation. So just think of the symptoms which respond to levodopa. They are the ones which will most likely to improve with deep brain stimulation. So what are those? Tremor, stiffness, slowness, motor fluctuations, ups and downs throughout the day, dyskinesias, and we may be able to reduce medication dose. Now, important thing to remember is tremor is one of the symptoms that even if it's not responding well to to medicine, it will respond well to deep brain stimulation therapy. Now let's look at symptoms which do not reliably improve with deep brain stimulation. So balance problems, speech problems, or memory problems, or autonomic symptoms such as blood pressure drop or constipation or urinary problems, these will not respond. Similarly, psychiatric problems such as depression, changes, or anxiety, even if it's even if it's the off related anxiety, they may not reliably improve. What about timing of the surgery? Is there a cutoff to get deep brain stimulation surgery? So there's no strict upper age limit, and age alone does not predict the outcome by itself. So there were studies done to look at whether the outcome is better in younger patients versus older patients. So overall, they can get similar improvement in their movement-related symptoms, but the quality of life is better improved in younger patients. And there are different reasons because older patients can have other medical problems which could be more disabling, and those could be the reasons, I think. But overall, there's no cutoff, but we look at their other medical issues and at the time we are evaluating them. So, if a younger patients in 60s or 70s, if they are having a lot of medical problems or other issues ongoing related to like cognition or psychiatric issues, they may not be good candidate. Similarly, if an older patients, 84, 85, if they are relatively healthy, they can be considered for surgery. What about the disease duration? Does that matter for deep brain stimulation? So, for deep brain stimulation and lesioning procedure, we often talk about like the window of opportunity, like where we are talking about the right timing. Now, can it be considered too early? I mean, it can be, but the concern is at that point, the diagnosis is still evolving because a lot of these other neurological disorders or atypical Parkinsonism, they can have similar presentation. And after a year or two, we start seeing other signs which can point us towards those atypical syndromes. So diagnosis is still evolving. So that's one thing. Other thing is patients may not experience more benefit with DBS compared to medication because they are getting good benefit from the medications right now. Adding DBS will not add anything more to what benefit they're getting from medications. So that's when we are talking about the right time is when the medications are working, they are going through ups and downs. That's when the medication, deep brain stimulation can be more impactful to them. And um, uh, other thing is we don't want to wait and for the later stages also, because at that point, patients can develop levodopa resistance symptoms, which may not respond to deep brain stimulation. And they can also develop other non-movement related symptoms, which could be more disabling to them as compared to movement related symptoms. So the duration by itself does not matter. I mean, we can discuss that early in the disease course, at mid stage, even sometimes in the late stage. It's totally based on their symptoms and medication response. But overall, we have to keep these things in our mind. So what happens during a DBS evaluation? Now, before the surgery, overall, we are questioning, can the symptoms still improve with medication? So if yes, then we are trying to optimize the medications. If not, then we are looking at other options and seeing, are the symptoms likely to respond to deep brain stimulation? If the answer is yes, if they are safe for the surgery, we can proceed. Now, important to know is DBS is not right for everyone. So not everyone will benefit from it. And the decision is always made together with the teamwork, which include us and you, I mean, patients and their family after weighing the benefits and the risks. So let's go through the typical surgical, procedure. I mean, a typical way the DBS procedure will proceed. Like so, before the surgery, if patients are considered good candidate, they will go through routine pre-surgical testing, which include psychiatric evaluation, neuropsychology testing, CT or MRI scan, and then day before the surgery, you will be asked to stop Parkinson's medication. On the day of the surgery, a small frame is placed on the head. This is to make sure we are accurately finding the specific region of the brain. And the CT scan is done to precisely locate the region. I don't know why it keeps moving. Sorry about that. And then the neurosurgeon will create a small opening, burr hole on the skull, and the thin electrode is placed in the selected region of the brain. And after a few weeks, the pulse generator is implanted under the skin of the chest. At UT Southwestern, usually the surgeries are performed while the patients are awake for a small portion of the procedure. So once the burr hole is created and we are ready to place the electrode, will wake up the patients, and then this time will are recording from their brain and looking at the brain signal. On the right, you can see that, and also doing the testing. So the patient participation is needed to make sure we are finding the target accurately. And once that is done, then the patients will go back to sleep and everything is closed and the lead placement is finalized. In some cases, a sleep procedure can be done if they are not able to stay awake, or there could be some other medical reasons. And there are different ways to do it, including using intraoperative CT guidance or intraoperative MRI guidance. What about the devices? There are three companies developing deep brain stimulation devices, Boston Scientific, Abbott, and Medtronic. They all have similar outcomes. They have similar kind of designs. They all have rechargeable pulse generator, so the battery will last for several years. But they all have like some differences, and these can be discussed with your physicians in more detail. So these can include, like, for example, some device can have feature to for remote programming, so patients can stay at home, and if they give us permissions, we can program the device remotely. Some device have the capability to record the brain signal to give feedback to the pulse generator to adjust the device. One of the device, Boston Scientific, have incorporated imaging to help program the device better, and also incorporated AI technology, and also some more advanced programming features. But again, if the lead placement is fine, I mean, they all have kind of similar outcomes. But we always discuss, regarding the devices to guide you and the patients and the caregiver to, decide which device will be best for them, or whatever device they prefer, we implant those devices. What about the surgical risk? Now, that's an important thing to understand. Now, the surgery is not a medical necessity, right? So it's not like like a heart pacemaker. If you don't do the surgery, the heart can, stop or go into irregular rhythm. Deep brain stimulation surgery is more for quality of life. So it's always important to understand the risk. So once you know the benefits and the risks, you can take an informed decision. So what are the surgical risks? Overall, it's relatively safe surgery, but there are risks, and these risks are real. So there's about 1 to 3% risk of bleeding in the brain. There's about less than 1% risk of stroke or seizures, very rare, and people can also have like some confusion after the surgery. And then there are device associated risk. So infection is one of them, which can occur in around 5% to 10%, depending on the studies. So usually the infection can be managed, and it is picked up early. Rarely, sometimes device needs to be removed out, but we have never had, and there's never a report where the infection has spread to the brain. So most of the time it's on the site where the battery is implanted or where the leads are connected. So it's mostly skin related infection. Other things which can uncommonly happen include hardware problems. There could be like damage to the lead, or the lead may move. And then sometimes the lead placement is not in a very favorable locations, and we realize that after we are programming the patients and they're not getting optimal outcomes. So we think about revising the lead. That can happen maybe in around 2-3% of the patients. And then patients can also have stimulation-induced side effects, which can be very temporary, including transient tingling, numbness, or pulling, tightness, or it can also cause speech changes or mood changes, and then balance problems. Now, most of these stimulation-associated side effects are manageable if we adjust the programming. But some of them may not be. For example, some patients can have speech fluency-related changes. Verbal fluency can be impacted. We try to adjust the device, but again, it could still be there despite the adjustments. But the severe side effects are related to stimulations are uh, does not happen. Most of the time, these are mild to moderate category of side effects. Okay, let's switch to lesioning procedures for Parkinson's disease. So what are lesioning procedures? These are the procedures which treat symptoms by creating a small targeted region area in the brain to reduce abnormal activity. So they're creating a lesion in a small region of the brain. So because we are creating a lesion, we don't need an implanted hardware, no battery or device maintenance is needed. It's usually performed on one side of the brain because both sides, if done together, increase the risk of side effects. And the effects are immediate. And then once it's done, it's permanent. So these are not adjustable. And there are three procedures which can be utilized to do the lesioning procedures. One of them is MRI guided focused ultrasound. Other one is radio frequency ablation, and the third one is stereotactic radiosurgery. Uh, Again, with the radio frequency ablation, we don't do that now. I mean, and then stereotactic radiosurgery is very rarely done. So my focus will be to discuss MRI guided focused ultrasound. So what is MRI guided focused ultrasound procedure? So uh, it's a procedure in which ultrasound waves are utilized to create a small, precise lesion in a specific region of the brain. So what is done in this procedure is the ultrasound waves are utilized to focus on a specific region of the brain, and as they are focused, they start heating the brain tissue. And as the brain tissue is heated, the brain cells starts becoming non-functional, and that's when we are evaluating the patients while doing the procedure to look for improvement in their symptoms of tremor or slowness. And if the improvement is good, then the intensity of the ultrasound waves is increased to make the lesions permanent. So basically, the brain cells are destroyed. It is done inside an MRI scanner, and the MRI helps to guide the treatment in real time, and most patients are able to go home on the same day. So there are three approved targets now for Parkinson's disease. The thalamus is one of them, which is used for tremor-dominant Parkinson's disease to treat only one side. So this can be used for patients who primarily have tremor as their major symptoms, and they do not have slowness or other stiffness or dyskinesia, but tremor is their major symptoms on one side. So that can be utilized. Other target which is used is globus pallidus. This can be used for slowness, stiffness, or dyskinesias. Again, can be done on one side because both sides it can lead to increased risk of other side effects, including walking or cognitive problems. And then more recently, last year, this third target called as pallidothalamic tract or PTT was approved, which can be done on both sides in a staged manner. So it cannot be done simultaneously, but you can do one side first and then later second side can be added. But for this target, more studies are still needed to see how patients do after getting this procedure done. Again, this is still a surgery, but it's an incision-less kind of surgery. So patients can have side effects. So what are the risks? So patients commonly experience dizziness, headaches, and pain during the procedure. These are usually tolerable. I mean, very, very rarely, like we'll have to stop the procedure because of that. But the other important things are like the risk after the procedure, because we are creating a lesion, patients can have, because of the lesion, there's a swelling in the brain tissue, because of which patients develop tingling, numbness on the side for which the lesion is performed. And then patients can have walking problems, speech problems, or weakness on that side, which is rare. Usually, these symptoms should improve over the time, and majority of them will go back to their baseline, but less than 10% of the patients can have one of these side effects, which can still persist. So how do you decide between deep brain stimulation and focused ultrasound? It's a shared decision. It's not like one size fits all approach. So we have to think about, and patients have to think about, do you need treatment on one side or both sides? Which symptoms are most important for you to improve? Do you prefer a permanent lesion or something adjustable? Do you like the idea of ongoing programming where you have to go for frequent visits or single one-time procedure? And again, patients' preference about the procedure, like whether they're okay with creating the incision and burr hole in the skull, or they prefer incision-less procedures. And always remember, like the right therapy is which once aligns with your symptoms, goals, and your comfort level. So, uh, um, okay, this is again. So I will just go over the workflow at UT Southwestern. So usually when patients are referred by a neurologist, they may see a movement disorder specialist here, or if they have been seeing movement disorder neurologist or a good neurologist managing their Parkinson's well, then they can see us directly in the neuromodulation joint clinic, in which a neurologist and a neurosurgeon will see the patients together, and we'll do an off and on evaluation, levodopa testing, and then we'll discuss about deep brain stimulation and focused ultrasound. If we think the patient is not ready yet, we'll continue with the medical management. If we think that, yes, I think this is the right time to proceed with the surgery, they will get additional testing, including neuropsychology evaluation, psychiatry evaluation, CT scan, or MRI, and MRI imaging. And then after these evaluations are completed, we discuss all the patients in a neuromodulation conference where we review the case again in detail to make sure that they're still good candidate, and then the surgery date is determined. Okay, so with that, I will stop here. Thank you all for listening. I'll stop sharing my slides, and then we'll go over the questions, and feel free to ask any questions you have.
Thank you so much, Dr. Sharma. This was excellent. A lot of the questions that people had posted ahead of this event, I think, were answered by this presentation. There are a few coming in, and everyone, please, if you want to raise your hand and ask the question, that's a possibility. But also, you can keep putting the questions in the chat. So, one of the questions we have here is, can DBS electrodes ever be removed?
Yes. So yeah, that's a good question, and a lot of patients ask this also. Yes, DBS electrodes can be removed. Is it usually performed? I mean, very occasionally, if patients are not getting a lot of benefit from the therapy, and then very occasionally we'll discuss, or for some other medical reason, that can be removed. But most of the time, even if we are thinking about adding additional leads, we still prefer to keep the older one. And there are studies done in long term that the DBS electrode per se does not cause any harm to the surrounding brain cells. So that has been studied. So if there's not a strong reason, then we prefer to keep the lead. But if there's a reason where we feel that removing the electrode can be beneficial, then we remove it.
Okay. Okay, we have a question that someone posted earlier, which is about how effective, and they didn't specify if you're talking about HIFU or DBS, how long does it stay effective for a patient?
Right. That's another good question which a lot of our patients ask. Uh, so DBS has been around for a very long time now. And of course, during this time, technology has evolved, and the devices have, changed and improved in several areas. So basically, with that, because of the duration, it's been there. There have been more studies to look at the long-term outcomes and particularly whether DBS is still effective. So the studies up to 10 years, 15 years, and where they found that even after that duration, there is patients can still benefit from deep brain stimulation. And of course, the degree of response starts declining. So, uh, so early on after the therapy, they will have robust improvement in their quality of life. And after several years of therapy, the quality of life measures, they start to plateau. So there's no further improvement. And there could be several reasons for that, which have not been studied. One of the things is after several years, the other non-movement related symptoms becomes more problematic. So that impact their quality of life more. But a short answer is yes, up to 15 years. I think like last year and maybe a year before that, there was one study at like my previous center, which I used to work, where they reported outcomes after 25 years, and they looked at the trajectory for 25 years, and they could see that the movement-related symptoms were still getting I mean, patients were still getting benefit in terms of movement-related symptoms, but that will start declining after 9 to 10 years. And particularly, patients will develop other things, balance problems or falls, which will not respond. For focused ultrasound, it's a relatively newer therapy. So we don't really have long-term outcome, so there's like outcome up to 4 to 5 years, but we are still understanding their long-term outcomes. And with time, we'll get like more data on that.
Mhm. Thank you. We have another question. When an implant gets tuned, how does the outpatient procedure work with the neurologist? Do they have options to use it in conjunction if they have a pacemaker? So there are two separate questions, I
Yeah.
guess.
So the first, I'll answer the second one first. So can DBS be implanted in someone having a pacemaker? The answer is yes. Does it impact the working of the pacemaker? No, it does not. And so it can be done, and all of them are MRI compatible. And usually these days, pacemaker are also MRI compatible. So so there should not be an issue about like making your pacemaker MRI incompatible. So that's like the answer to the second question. The first question is like how it is tuned. And so basically, once the DBS is implanted, we like to wait for a couple of weeks because once the leads are placed, the patients can have a stunning effect. And with that stunning effect, only patients can feel improvement in their symptoms. So we want to wait for a couple of weeks so that the stunning effects go away and patients are back to their baseline with regard to their symptoms so that we can really see the impact of DBS therapy on their symptoms. So what is done, patients will be brought in after 3 to 4 weeks, and then we'll slowly start ramping up the stimulation. And there are different regions in the brain at which we can stimulate. And we'll go through these regions one by one, and we'll stimulate these regions and then see the impact on their symptoms, whether it could be tremor or slowness, or it could be um, stiffness, and then we look at how their walking is. And then also we look at whether they are experiencing any side effects. So the first visit is to determine the range. What is their window in which we can like program? And then uh, then the subsequent visits are done to refine that programming to see like how well they're responding and then how much medication needs to be adjusted. So we'll go up on the stimulation, we'll cut down on the medications, and then looking at the impact of adjusting the medication, because sometimes we lower the medications and they may come back saying that, okay, I'm not thinking as well since we reduce the medications, or my speech has declined. So patients may still need medications for some of the areas which are not getting better with deep brain stimulation. So usually the visits are around 4 to 6 weeks apart for the first 3 months. And then once they are doing better, then we start spacing out the visit. And so it will go to the same frequency as their regular follow-up at which could be like anywhere from 4 months to 6 months follow-up.
Okay. Uh, there's a question, and I know you answered that for part of the procedure, the patient has to be awake, but does surgery require general anesthesia ever?
So yeah, I think like so there are two parts of the surgery. When the first part is when the lead is implanted, when patients are awake for a portion of the procedure. During that time, there's no general anesthesia involved. They will have conscious sedation. Basically, they will be given some sedatives, so they are in deep sleep where they're creating the burr hole, but they don't require intubation or anything. And how it will be kind of similar to when they, what sedatives they get for colonoscopy and those kind of procedures. And then we are able to wake up the patients. For the second portion, when they're implanting the battery in the chest, because it involves tunneling of the wire below the skin all the way up, and they are under a general anesthesia and for a brief duration. So,
Mhm.
and then once the procedure is done, they go home same day.
Okay. Uh, is there a success percentage for, would it ever happen that it doesn't work after the procedure? I think there's a question around that.
That's another very good question because, again, uh, it's uh, so first of all, like the success rate. So majority of the patients will have good improvement. So when we are talking about majority, I would say like more than 80% of the patients will get good improvement. But the range of that improvement can vary. So in general, we talk about on an average, patients can experience around 3 to 4 hours improvement in their on time. But that can vary. Some patients can experience 3 hours. Some patients can experience less than that. Uh, but are there patients who did not get good benefit? So yes, there can be patients who are not benefiting a lot. When that happens, what we do the troubleshooting part where we are looking at what are the reasons
Mhm.
because of which they are not experiencing good benefit. And the reasons can be several. And so we go through all of them one by one. First one could be whether the diagnosis was correct or not, you know, um, and then other things could be whether the expectations were reasonable, or, so whether, patients is still getting good benefit, but if they were thinking about, oh, I should be like totally smooth throughout the day, and that's not happening, then we are discussing the expectations again. Then also looking at the programming, where the programming has been optimized. Can we do more adjustments? Or other thing could be whether the lead placement was good.
Mhm.
So we look at the lead location. So there are several factors we look into that. And despite that, I mean, occasionally there could be patients that, they're not getting a lot of benefit where the programming has been optimized. And that can be seen, but it occurs occasionally. I would say less than maybe 5% to 10% of the patients. But despite that, when sometimes we see, okay, there's no benefit, we'll ask them to turn off the device. They'll come back and saying, oh, actually in some areas I'm getting benefit.
Mhm.
So if the candidates who were appropriately selected, I think they should be getting some degree of benefit.
Okay. Well, we have a question about the device. Is it accessible by hackers?
That's a very important and reasonable question too. Yeah, so when these devices are being made, there's been a lot of regulations which FDA wants, and that's one of the things which they look at. They all have their proprietary technology, the way they connect to the programmer and to their patient's controller, because patients will also get their controller.
Mhm.
So it's Not easily. Yeah. So no, but again, is everything 100% safe? No, I mean, but yeah, but I've never had any case out of hundreds and hundreds of patients where there were any issue because, there was hacking or something. So, it's not accessible. Uh,
Okay. Well, that's all the time we have for questions. Let's
there's like
see. There's
one
one
last.
more. Yeah. DBS, can it improve slowness? Yes, let's just answer that last
Yeah.
one.
So the DBS, yes, it can improve slowness if it's responding well to levodopa.
Mhm.
So when we are talking about slowness, we are, again, are we talking about slowness of gait? If that's the question, yes, if the gait is responding well to levodopa, DBS can improve gait related slowness. What about the movements, like getting out of the chair uh, or the hand movements? So as long as they are responding well to levodopa, it will improve. But that being said, slowness out of tremor, rigidity, is respond less compared to those symptoms.
Mhm.
So patients can come back saying that, "Oh, my tremor is better, I feel less stiff, but if I'm trying to do some movement, I still feel like there's lack of dexterity or difficulty with writing or doing some fine motor tasks." So that can still persist. So it won't take away completely, and in some patients, that can be difficult to respond. But if overall their slowness is responding well, it should improve the slowness also. To levodopa, then it should improve slowness also.
Okay. So before I go back to you, Dr. Sharma, for any last thoughts, I just want to say that please provide feedback. Whoever is attending, you will receive a feedback form so that we know what kind of more programming, educational programming we can do. So please fill out that feedback form. And with that, I'm gonna ask Dr. Sharma if he has any last words. And this presentation is being recorded, so it will be available on our Total Care webpage as well. Yes, Dr. Sharma.
So I just want to emphasize that uh, the surgery, as I mentioned, it can be intimidating. So having the right information is important, and always discuss with your physician, even though if you're not ready, because it will take some time for patients to become comfortable with the idea of surgery. So knowing the option, understanding about them, so that when the time is right, you can consider those options. And and again, there is another thing is there's a lot of material out there like marketing stuff and which can create unnecessary enthusiasm also about the surgery. So that also you have to be careful and not necessarily jumping to one particular thing or procedure like suddenly. So always discuss with your team, and we are always here to help you all, and feel free to reach out to our program for any questions at any point of time. And I really like this series. I think like it's a good way to interact with the patients. So, looking forward to, as Numa mentioned, to continue it with some other topics.
Yeah.
But thanks again for organizing this.
Thank you so much, Dr. Sharma, and everyone who attended. Have a good weekend.